Okay, wonderful. Well, thank you, everyone. I think everyone from Larry Mullen's lab probably doesn't recognize me because usually I'm sitting in a shadow in my pajamas when we do our Zoom calls. This is the most light they've seen on me, probably. So anyway, we are pleased to be here. And I know last time Larry showed some pictures of Oklahoma and his dogs. And Oklahoma is beautiful, and I miss being in Oklahoma City. But I'm very fortunate to keep working with Larry's group at OSU in Stillwater. And I just wanted to say we have a collaboration between Oklahoma and now Montana, which is where I currently live. And the picture on the left is the summit at our ski resort. If you like to downhill ski, you can take a tram up to the top and ski down. And then the picture on the right is my road. So I'm extremely fortunate. I get to go on long walks every day and think about things like DSD and surgery, and I get a lot of peace and quiet to think about these things. So I'll share some of what I've been thinking with you. And I'm quite sure that all the really good slides are going to be from Katie, but sort of bear with me and we'll try to, we'll get through this talk. Okay, so we were discussing before everybody came on, sort of the importance of knowing the history of DSD to understand how we got here. So we have split this talk up into 3 parts. What do we know from the past, particularly in the context of genitoplasty, early genitoplasty and mental health? Katie is going to share some really nice data from both her papers and other people from the lab, many of whom are here today. So what do we currently know, sort of the studies that are ongoing right now, and then we want to end by talking about how might we move forward. So I want to start with this person. This is Hugh Hampton Young. And some of you may know he was a urologist at Johns Hopkins School of Medicine. And it's important to know who Hugh Hampton Young is to understand why historically there was an emphasis on what type of gonad a person with DSD has, and also feminizing surgery for people with ambiguous genitalia associated with their DSD. And why did this happen? Well, first, let's step back and consider that Young pioneered general reconstructive surgery in the 1930s to the 1960s. And this was at a time when it was difficult to determine the true sex of a person with DSD. So just to kind of remind us, the use of buccal smears to determine sex was not available until 1956. Karyotyping came much later than that. The use of mass spectrometry to measure hormones and serum was not available until the 1960s. So that meant that physicians relied on the visualization of gonads to inform a diagnosis of DSD. So if a child or an adult presents with ambiguous genitals or secondary sex characteristics, these physicians would essentially look to see, does this individual possess both ovarian and testicular tissue? That would be a true hermaphrodite, what we now refer to as ovotesticular DSD. Do they possess testes, what used to be referred to as a male pseudohermaphrodite, or do they possess ovaries, what we used to call a female pseudohermaphrodite? So that's where that terminology came from. And I think it's striking to remind ourselves how limited these physicians were when trying to understand the presentations of the patients who they were working with. Now, on top of that, Hugh Hampton Young said that for patients who were characterized as male pseudohermaphrodites, that was the terminology of his time. Again, these would be people who were genetically, he didn't know their genetics. These would be people who possessed testicular tissue, but had DSD. Young said it was easier to reconstruct female anatomy if that person had ambiguous genitalia. And then similarly, Lasso Wilkins said that for those who were female pseudohermaphrodites or DSD individuals who possessed ovarian tissue, and we now think of this primarily as 21 hydroxylase deficiency or congenital adrenal hyperplasia, there was also a preference for female rearing. And this came mostly from Lasso Wilkins, who was a pediatric endocrinologist at the time. And this was because Wilkins knew that if these patients were reared female and treated with cortisol, that they had fertility potential. But if they were raised as male, they had no fertility potential. So where did the emphasis on early surgery come from? And that was not Young. Young actually did most of the surgeries that he pioneered in adults with DSD, or at the time were called, again, male pseudohermaphrodites or female pseudohermaphrodites. And it was John Money, who was a psychologist who worked at Johns Hopkins, who came up with what we now refer to as the optimal gender policy. And this is basically, there are many components to this policy, but the one I want us to think about now is that Money proposed that gender identity is learned. And he said that gender identity is very similar to language for humans, where humans are predisposed, we are born with brains that want to learn a language. But what language we learn depends on who our parents are and what culture we live in. And similarly, Money said, we are predisposed to have a gender identity, but what gender identity we develop relies on learning, or sort of the social construction of our gender. So he said that humans are biologically predisposed to have a gender, but what gender they have is learned. Now, Money also said that sex of rearing for infants with DSD should be based on genital anatomy and fertility potential, similar to Lasso Wilkins. And again, feminizing surgery continues to be preferred over masculinizing surgery, because the surgeons told us that feminizing surgeries were technically easier to perform. And then finally, Money said that early surgery to maximize gender appropriate appearance was recommended. So he said, you know, if a parent is raising a child, say with 21 hydroxylase deficiency as a girl, it was important for that child to look like a girl, so that others in that child's environment truly treated her like a girl and that she could see herself as a girl. So Money was the one that really proposed early genitoplasty, not the surgeons. Okay, but then we started to accrue evidence that perhaps humans are not born gender neutral, as proposed by the optimal gender theory. So where did that evidence come from? And on the left here is a New England Journal of Medicine paper. Some of you remember this paper. And this was actually not in individuals with DSD. These were in individuals who had exstrophy. And essentially, just like in DSD patients, individuals with exstrophy who are born with atypical genitals, again, the surgeons prefer to do feminizing surgery. So these are individuals who were genetically male and were initially raised female predominantly, because that was the type of surgery that was easier for them. But what we see here is that many of the patients who were originally raised female then initiated sex reassignments back to male. So at the last follow-up, several of this sort of case series was living as male. So the first evidence that perhaps you can't just take a child in the first 2 years of life and assign gender according to what anatomy or what a surgeon thinks is more likely to be the best option. The other part, or the other evidence that contradicted the optimal gender policy was this case. And some of you remember this case. This is the John Joan case. And there was a book written about this case, As Nature Made Him. Now, this child also did not have DSD. This child was a perfectly healthy boy who had a circumcision accident. And as a result of that accident, was raised as a female. But similar to some of the exstrophy patients, although initially raised female, this child reassigned himself to male in early adolescence. So this was all happening in the late 1990s, early 2000s. And so people said, well, maybe we need to go back and look at the DSD patients and see what's happening with their psychosexual development. Okay, so here is some work that I did with Claude Mijon in the early 2000s. So we went and we looked at individuals who were now born with DSD, not exstrophy, not a circumcision accident, but they truly had DSD. And these were all individuals who were born with ambiguous genitalia. And this case series, these individuals were raised as males. So we wanted to look at gender, but we also decided we wanted to look at surgical outcome. And what we found, if you look here, total number of genital surgeries, you see some of these individuals had more than 10 surgeries in their lifetime, but we would see numbers like 5, 6, 8. So high numbers of surgeries. So that suggested to us that people like the early surgeons who proposed feminizing surgery was preferred might be onto something, because these patients required many, many surgeries. And despite that, the cosmetic appearance was not very satisfactory. So basically a higher number indicates a poor cosmetic outcome. And you can see we have high numbers here. And this was true whether we rated the appearance or the patient rated it themselves. And then furthermore, when we looked at sexual functioning, again, many of these men told us that they were dissatisfied with their sexual function. So maybe those early surgeons were onto something. Maybe it is extremely difficult to reconstruct male genitals that both look satisfactory and function in a satisfactory way from ambiguous genitalia. We similarly went on and looked at our females. So these again were individuals with DSD but raised female. And these individuals required surgeries. Whether we rated the appearance or asked the women to rate the appearance itself, a better cosmetic outcome. However, when we looked at sexual function, it was no different than the males. So these women were largely dissatisfied with their sexual function. So we took that to mean that the surgeons were correct in that you can construct female genitals from an ambiguous phenotype more successfully with fewer surgeries and a better cosmetic outcome. However, sexual functioning was not necessarily better in the females. In 2006, there was a consensus meeting in Chicago. I know David was there, probably others who are listening to this right now were there. And a number of statements were sort of put in this consensus statement. And one is that we should be providing interdisciplinary team care, and also a molecular diagnostic approach was encouraged. So we're now going away from this reliance on the gonad, and now we're looking at, well, why does this individual with ambiguous genitalia and testes, why did this happen? Was it androgen insensitivity? Was it a testosterone biosynthetic defect? Was it an enzyme defect like 5-alpha reductase deficiency? So we got, I think, much better at categorizing patients who we were treating and studying, but it also made things much more complicated. Early surgery continued to be endorsed by this consensus statement. There was a change in nomenclature to now refer to individuals with DSD. And some people say now we have too much of a reliance on genetic sex, where before perhaps there was too much of a reliance on gonadal sex. And now male sex rearing is preferred in some patients with XY DSD. And again, that was different from what we saw from early urologists and some of the earlier physicians who were treating these patients. Did people adopt these suggestions? In the study that we're currently conducting, these are 12 different sites across the US. And this is work done by Courtney Finlinson from Chicago. And what we found in our current study sample is that, in fact, yes, people are adopting many of these suggestions, including the individuals who are XY are actually being predominantly raised as male, where historically they would have been raised as female. Okay, we also saw the involvement of patient activists. I'm sure many of you are aware of this, and I suspect this will come up in questions later in the talk. But so we're kind of seeing a change in treatment. Some of that changes in response to the activism. And we're seeing the sort of the role of activists, I think, evolving over time as well. And we're also seeing involvement in human rights professional and legal groups. So we saw quite a bit of activity out of Europe. Human Rights Watch became involved also in the US more recently. And then in the US, we've had the AMA get involved. There was a case in Carolina at the Medical University of South Carolina, US Surgeon General's, and then finally this year, Lurie Children's and Boston Children's. And we also know of some efforts in certain states like California to use more of a legal approach to change the treatment of children with DSD. Okay, so from there, I'm going to hand it back over to Katie, and she's going to talk about some data that we've collected.
Thank you, Amy. So the current R01 project that we have, along with many sites and many folks on this call, follows a cohort of children diagnosed with within the first 2 years of life with the DSD, specifically with moderate to severe genital atypia and their parents. And families are recruited across 12 US sites. In addition to medical information, parents are completing measures of psychosocial functioning annually for up to 5 years, and the study has been extended to collect data up to 10 years after baseline, with children also completing self-report measures after they turn 8. So of note, the children included in the study do not have organ malformations outside the reproductive system, meaning that those with exstrophy that Amy discussed earlier would not be captured in this study. Just wanted to make that distinction. So findings from the study indicate that the majority of parents and their physicians were not satisfied with the child's genital appearance at birth, with physicians reporting greater dissatisfaction than parents and mothers reporting greater dissatisfaction than fathers for dyads. Among children who received genitoplasty, parents and physicians reported an improvement in satisfaction post-surgery. Of note, 7 children did not undergo genitoplasty. Therefore, we can't really draw strong statistical conclusions about this group, but we do have that small subsample. A recent growth mixture modeling study from this cohort demonstrated 5 subgroups of parents based on their depressive symptoms over time from prior to surgery, if surgery was chosen, to 1 year post-surgery. Most parents demonstrated a resilient trajectory, which you see in the green line, with few depressive symptoms at baseline and over time. The next largest subgroup is defined as recovery, with depressive symptoms remitting over time. About 7% of parents demonstrated a chronic profile in which depressive symptoms remain elevated over time. And for a small group of parents, their depressive symptoms increased over time. And lastly, the smallest group of parents had the highest initial depressive symptoms that remitted over time, but remained relatively elevated. Although speculative, parents' symptoms may lessen when their child's external genitalia more closely aligns with that sex of rearing, kind of post-surgery. However, obviously future work needs to examine predictors of membership of this group, as well as the makeup of these various groups of parents that tend to improve or worsen, stay the same over time. A recent examination of decisional regret among parents of girls with CAH within our study cohort found that the majority of parents do not report any regret regarding their first decision made about their child's ambiguous genitalia after talking with their doctor. So although the language of the current measure captures regret regarding a first decision, however, parents may define that for themselves rather than specifically asking about any surgery decision-making. A qualitative analysis of parents' write-in responses found that when completing the survey, 80% of parents were considering their child's genital surgery when completing the questionnaire. And other themes extracted included the timing as well as the type of surgery. Additionally, greater reported uncertainty at baseline about the diagnosis predicted higher decisional regret at follow-up. So perhaps there is that component of knowledge, familiarity, and things like that that might contribute to feeling confident in one's decision. However, we obviously need to explore these things much more. And we're currently looking at this data for boys, our CAH boys separately. And we should hopefully learn more about these things over time as well. So for parents electing for their child to receive surgery, avoiding stigma arising from atypicality of genitalia is often anecdotally and qualitatively cited as one of the primary reasons, related to findings from our study that highlight that parents' report of stigma is associated with their perception of their child's diagnosis interfering with their daily lives, which in turn was related to their adjustment post-diagnosis and post-surgery in some cases. In other words, it seems that experienced or anticipated stigma arising from the child's diagnosis is related to how parents choose to engage in daily activities such as work and social involvement. However, it is unknown how this experience or anticipated stigma may influence decision-making surrounding genitoplasty, as well as the degree to which families either disclose or conceal their child's diagnosis from others. Of note, although our data are cross-sectional for that study, no differences in stigma were found across time point or pre-post surgery for those families that did elect to receive surgery. This suggests that surgery may not entirely allay concerns, or perhaps new concerns related to stigma arise later on about their child either being treated differently due to their diagnosis. Future research should examine the role that stigma has in this treatment decision-making, as well as any long-term regret or satisfaction with surgery outcomes. And with that, I will pass it over to Amy again to kind of talk about how we move forward.
All right, thank you. Let's see here, sorry. Oh, let's see, Katie. For some reason, it's not giving it to me. Okay, there we go. Okay, so as Katie just mentioned, we do ask both mothers and fathers, as well as the surgeon who's treating the child, to rate the cosmesis of the child's genital phenotype at study enrollment, which would be baseline prior to surgery if the child receives surgery, and then 6 and 12 months post-surgery. And as she said, what's shown here in the orange and red is dissatisfaction. So we're seeing mostly dissatisfaction that is then looking better or more satisfaction post-surgery. So this is short-term satisfaction, again, 6 to 12 months post-surgery. The question is, will children themselves be satisfied with the cosmetic outcome of their surgeries as they age? And then getting back to those original Mijan papers of the early 2000s, what about sexual function? Because remember, we did have patients who had a good cosmetic outcome, but still a poor sexual function outcome. So we are going to wait as these children age and see if we can determine some of those things, some of those questions, answer them. Again, if we look back at Megan Perez's data that were just accepted for publication, actually, what we see are these different trajectories that different groups of parents show when we ask them about things like anxiety and depression and all types of mental health measures. So the question is, over time, are these trajectories changing as a result of their child has received surgery or some other treatment? Could it be mental health treatment the family is receiving? Is it simply the fact that the parents have been living with DSD now for some time and they're getting used to it? Or are there other factors that are impacting some of these trajectories that we haven't even considered yet? And then one thing that we've talked about quite a lot in our lab, will trajectories change if parents are unable to choose for themselves whether or not surgery is an option for their child? Now, remember, Katie said 7 of the children in our study have not received early genitoplasty. We have 99 children in our study. The majority of parents opted for early surgery, despite the fact that they're aware of the controversy surrounding surgery. So these again are more questions we can be asking. And again, getting back to Rachel's decisional regret data, most of our parents said they had no regret, again, despite the fact that these were now parents of girls with CAH. Many of these girls had clitoroplasty, vaginoplasty, labioplasty, and these parents are fully aware of the controversies surrounding those surgeries. So as surgery becomes less available, will these regret data look different? We don't know. And then one of the drawbacks of our study is the parents in our from our 12 sites tend to be very homogenous. They tend to be white, upper income, educated. So what about other parents? We all know parents who don't fall into those categories. Are they going to feel similarly to the parents whose data we're showing here? And we don't know that. So again, we would like to have a more representative group of parents to ask these questions to, as well as start to factor in for some parents for whom surgery is not very easy to obtain. If they want to obtain it, how will these data look different? And then getting back to Katie's work with stigma, you know, again, as surgery becomes more controversial or unavailable, will this impact stigma? I know anecdotally that there are parents who don't want to join certain groups because they've decided to have surgery and they feel like other people in that group if they discuss it. How will it impact daily living? And then will there be an impact on their mental health or their child's mental health, or both? So again, all questions we can be asking as we move forward. I want to throw this out. I know many of you work with children with gender dysphoria in addition to children with DSD. And we don't know much about kids in the US who have ambiguous genitalia, but who have not had early surgery. Although those children are out there, just like we have 7 of our group, we haven't studied these kids in large numbers. But we do have converging data from other children that might inform us on what may happen with these children. If in fact they are being raised with ambiguous genitalia in a family where the family perhaps would not have made that choice if it was left up to them. So now let's consider kids with gender dysphoria. And we know that the prevalence of depression and suicidal thoughts and even suicidal attempts are higher than in kids who don't have gender dysphoria, and that this is prior to receiving medical or surgical treatment. And we know that psychological function improves following puberty suppression and cross-sex hormone therapy, and also surgeries. So one of the questions that I have is this indirect evidence that growing up with genitals that don't look like your gender identity is putting you at risk for distress? And again, I think we will learn about this as time goes on, but we don't know the answer to this question at the moment. And then these are some data that Larry Baskin published earlier this year, or last year, I should say now. And again, we continue to look at surgical outcomes. And surgeons tell us surgery is always getting better and it's always evolving. However, surgeons do surgery differently. So one of the things that I was really surprised with our data is how different surgeries are happening. So these are data from girls with CAH. And my only point of putting this table up is to show you even surgeons within an institution are doing genitoplasty differently. So it makes it quite difficult to assess outcomes if we don't have a standard way of doing an intervention. And then this makes me think about, could we say the same thing about mental health? So how do we know if what we're doing works if we're not even sure exactly what's going on, whether it's in the surgery or mental health or endocrine treatment? So as we move forward, I think it would be a good idea to standardize care and then conduct research to determine what is the most effective approach. Is multidisciplinary care the most effective? And I'm hoping we have some discussion about that. What about shared decision-making? I know Dave is going to talk about that at his masterclass, but again, how are we doing that? Are we measuring it? Are we looking at outcomes? How often do parents meet with mental health providers? What happens during those meetings? How are outcomes assessed? And then another thing that I'd like to throw out there, do we need specialized training? I get calls from people a lot. I know David does. You know, people have lots of specific questions. They feel like they're seeing something that they haven't seen before, and they have questions about how to proceed. Do we need to be giving our mental health providers, you know, training on the history of DSD? Why are we doing the things we do? How did we get here? So that's something I hope we might discuss a little bit at the end of this. And then finally, targeting care for those who will most benefit. For those of you who actually work in clinics, you know how limited your resources are. And as surgery goes away, our resources will be even more limited than they are right now. So how do we deal with that? And when I went back and looked at the literature on effectiveness of interventions for parents who have children with chronic illnesses, I was not able to find a ton of data actually, but here is one study that I found looking at parents of kids with various chronic illnesses. You see them listed here. And my point is, if we look at the group shown here in the black square, this is the experimental group of parents with high anxiety. After a mental health intervention, what we actually saw was anxiety decreasing in these parents. But if we looked at the group with low anxiety who got the same intervention, we saw nothing, no difference. And this makes me think back to Megan Perez's data, the different trajectories. Do we throw the same thing at every parent, or do we simply target the parent who is most likely to benefit from an intervention that we've tested? Similarly, if we look at self-esteem, again, if we look at now the control group, so the group that got no intervention with low self-esteem, we actually see a decrease in self-esteem over time. These people got no intervention. But here, the experimental group with low self-esteem, we see an improvement. So what this tells me is we're not just looking for improvements in measures, but maybe even we're looking for not seeing a decrease in a particular measure. So I think these are indirect evidence that the parents of children with DSD could benefit from interventions, but again, not throwing it a blanket across everyone, but really figuring out who is going to benefit and then how are we going to intervene with those people. So this is a slide I put in here for Amy Tishelman because I have to tease her. So this is Lasso Wilkins. I can't see Amy. I wish I could see her right now.
Here I am.
There she is. Perfect. This is for you, Amy. For those of you who, again, may not know the history of DSD, there's a huge feud between Hopkins and Boston Children's on who was the first pediatric endocrinologist in the world. And those of us who trained at Hopkins would say, this man, this is Lasso Wilkins, and we say he is the father of pediatric endocrinology. But Amy Tishelman would tell you, no, I'm wrong. Jack Crawford is the first pediatric endocrinologist. So you see, we can't even agree on who the first ped endo was, right? So where does that leave us? But I love this slide because not only does it include Claude Mijan, who was my mentor, whose data I referred to earlier in our talk today, but it includes his first group of fellows. This was Mel Grimbach, Judd Van Wyk, Shepard, Mijan. You know, Grimbach went on to work at San Francisco, Van Wyk at Chapel Hill, Mijan stayed at Hopkins. I'm actually not sure where Shepard went, maybe David knows. But nonetheless, there was such a history of training and doing it in a way that was evidence-based that I think we could so much benefit from in promoting today, as opposed to, I think, kind of reacting to a lot of anecdotal reports that we're getting. And to remind us of why that's so important here, Lasso Wilkins is holding a ruler. And Wilkins said, observe everything, measure everything, and report your data before you make big conclusions or big policy statements. And I think he's absolutely right. And I think that couldn't be truer than today when we're talking about DSD care. So Lasso Wilkins or Jack Crawford too have a lot to teach us as we move forward. And we have a lot of people to acknowledge. First, our participating families, all of our sites who generously give us their time, the NIH for supporting our work. And with that, Katie and I would like to try and answer your questions. So we purposely left time because we know this is a hot topic right now, and we would like to hear your experiences, again, so that we don't rely on our own anecdotal experiences, but try to be more objective and research oriented.
This is just a really amazing conversation, and I've appreciated learning from Katie and Amy today. Thank you so much.